Good morning and good afternoon to those who have joined us today, and welcome to the first TeamSTEPPS 2.0 online webinar. Our goal today is to share key points from the first three modules, which would be team structure, introduction, and communication. But the main focus of this webinar is for you to speak up in the chat box, of course, ask questions, and share how you're moving forward with your initiative or any concerns that you might have. As an added bonus, our guest speaker today is Tiffany Christensen from Duke University Health System. Unfortunately, Dr. Charles Murphy got called away on a real-time emergency. So let's begin with a couple of polling questions first today. You'll be prompted to answer the polling question in the webinar platform, and just please select the appropriate answer and then submit. So our first question, I'm taking this course as a member of a team. Please just check yes or no. Or I'm taking this course as an individual, and again, annotate yes or no. And then if you will, mark all the modules that you have completed, so module 1, 2, 3, or all of them if they all apply.
And Dr. Kraft, we should have those poll results in just a moment.
Oh, great. Thank you.
And you should see the results now.
Okay, so it looks like 71% of you are taking this as a member of a team. Well, okay. First. Oh, it's no. I am so sorry. Thank you. My trusty partner here is keeping me online, folks. Actually, 71% of you are taking the course as an individual. And 71% of you have completed Module 1, 71 Module 2, and looks like 57% have already completed Module 3. Awesome. Okay, so if we'll go, we have one more polling question, and that is my organization's change team is already in place. And again, if you'll just mark yes or no if you have a change team already formed.
And Dr. Kraft, we should have those results in just a few seconds.
Okay.
And you should see the results now.
Okay, so it looks like, oh, we're about even. 56% have not yet formed their change team. Okay, so the change team really will look at the big picture, including the strengths and deficiencies in your current practices, as well as that current status of communication and teamwork in your organization or work unit. The team's going to identify what changes need to be made and what specific practices, tools, resources will be needed to implement those changes. And these steps I just described are based on the principles of quality improvement, QI, which defined broadly will include system redesign as well as process improvement. Integrating your teamwork improvement efforts into a coherent QI framework really does aid success in your efforts as you seek to improve the safety and quality of care by enhancing communication and teamwork. So again, that change team really has a lot to do with the success and speed of adoption of your evidence-based clinical practices. Having that infrastructure dedicated to the redesign of a particular process of care is important as well. And the center of this infrastructure, of course, is that interdisciplinary change team that has a strong link to hospital leadership, members with the necessary expertise, a clearly defined task, for example, identifying a specific opportunity for improvement that could be realized with enhanced teamwork, and formulating a vision for the TeamSTEPPS initiative. and access to the resources needed to complete that task. Now, trying to find one person who can do all these things just doesn't work, okay? You really need a team. When we talk about communication and teamwork, this is a process that cuts across many different areas of hospital operations, so you really should have input from all those areas. In addition, forming the team ensures that efforts will continue even if one or more members must step down or move to another area or have to attend other responsibilities. The change team generally assumes overall responsibility for the design and evaluation of your change initiative in clinical practices and working with and through other teams within that facility. These relationships among the various teams was discussed in Module 2 when we mentioned the importance of team structure. So successful teams have capable leaders who help define roles and responsibilities and keep the team accountable for achieving their objectives. Senior leadership support is a prerequisite for system change, but change itself comes most efficiently, as I think you all realize, from the ground up. Change happens as teams that include frontline healthcare workers, such as physicians, actively engage in high-priority problem-solving, such as redesigning your processes of care. Your interdisciplinary team will also have the responsibility for initiating the initiative in your organization, making key decisions about the design, commissioning other teams at the unit level to carry out the improvement activities, and monitoring progress. So while the team may not be involved in hands-on care, it is essential that it includes members with clinical expertise and experience that can share that experience during the team's deliberations as they're planning the change initiative. So let's look at an example of a team focusing on falls reduction. Looking at the change team's composition, is there anybody that you might add? Go ahead and type your suggestions in the Q&A box. And I'll give you all a few time to look at this change team and see who you might want to add if you're looking at a falls prevention program. Okay, I see someone typed in provider. You are spot on. If you're working with falls, you want the whole team involved as the member of your change team. You want to get that provider. And anybody else when we're talking about falls? Okay. Clinical quality, I see. And somebody from Med-Surg, right? And they have their Med-Surg nurse listed. And I see someone added patient and family advisors. Absolutely. Let's not forget to include the patient as we're able on our teams. The other thing you might want to consider is a pharmacist, so that you have that input about the medication usage and how that impacts our patients. Okay, awesome. So we'll go on then to the next slide. So when we looked at Module 1, the introduction, we talked about teamwork and how that plays a critical role in providing health care, but key is the implementation of your teamwork principles, not just your training, checking that box to say we did that. And when you're speaking with staff or leadership, include in your discussion the common causes of events in your unit organization, perhaps starting with the top 3 or 4 causes. Make it personal. What really is going on? Why do they need to think about a process for change? If communication's in the top 3, specify what about communication is the culprit. Communication is such a broad umbrella. Is it ineffective handoffs, lack of team communication? Do you have staff that assume that if they know, everyone knows? Point to the importance of team sharing accurate and timely information when you're having your discussions. In this way, you're educating, setting the stage, if you will, as to why they really need to take this seriously and work to implement those changes. If the Sue Sheridan video doesn't resonate in your organization, this is an opportunity to share a story of something that happened or could happen in your own work area or organization. Discussions need to focus on, what might we learn from this, or what would you do differently? The point is there is seldom one cause to any event. Staff don't routinely come to work planning on making an error. Often it's the process and the work environment in which we expect staff to function that aids in that error. Is the process too cumbersome? Do staff devise workarounds that are not known to the entire team? Is the process outdated or not clear? And are staff held accountable? Sometimes it just involves poor technical expertise. If you think about it, it's easy to make a mistake when you're spending 100% of your time struggling to do your job. I know I'm showing my age here, but if any of you are I Love Lucy fans, if you remember when she was working in the chocolate factory and that task as simple as putting the chocolate into the box really was a disaster. She tried to do her best. So you want to engage your staff. Use your staff power, their ideas to create solutions to your problems. I once heard someone describe this as using their stories like an on-ramp that allows you to learn and find solutions. Being invested in the solution and the outcome aids sustainment. It's much better to find the solution yourself than waiting for an outsider to come in and do it for you. And so in Module 1, then we also provided that overview of the many resources available to you, both online and in hard copy. If you haven't already done so, I recommend you order the Pocket Guide for your staff so they can use that as a reference when they begin to use the tools and strategies and behaviors in their daily practice. And listed on the slide is the link where you can order the Pocket Guide and other resources. And that's teamsteps.ahrq.gov/abouttoolsmaterials.htm. So I'm going to stop now and see if there are any questions or comments or anything you'd like to share with your colleagues.
Yes, in Module 1, the speaker said TeamSTEPPS was customizable. Is there a point at which altering the course impacts its value, i.e., leaving out one of the components, such as identifying the types of teams?
Oh, that's a good question. All courses are customizable in order to focus for your audience that you're teaching to. We encourage you to make your training clinical, as applicable, and customizable to the unit. And by that, we're referring to the various videos and exercises that may be used, or you can customize with your own examples. Not that you can choose to delete aspects of the curriculum when teaching the course. For example, when you're planning the training, take some amount of time to understand the flow of patients. Who are the frequent physicians that participate on the unit? And also understand from the unit directors and others on the unit what the major interaction problems are that occur. And then during the training, take a serious or sentinel event where teamwork had failed on the unit and use that as the centerpiece of the training. And then you can also use that same case history at the end of the training and ask participants to use what they've learned and revise the case using their teamwork skills so that it didn't occur as it did with the bad outcome. Now remember, if you choose to use your own examples or case studies, you're going to need to scrub each example of its identifying details. Confidentiality and compliance to HIPAA regulations and protocols must rule all discussions. As well, the cases discussed should be closed cases. When in doubt, check with your risk management department. And then the course management guide, which can be found by selecting the same link that's on the slide and then just typing in management guide in the search field, is designed to help people understand how they can teach a master training course or fundamentals and essentials course, and discusses customizing the curriculum as well as detailing the course version. So team structure, Module 2. Now, we did mention during that module that understanding the structure and compositions of teams in your organization is really important to be able to learn how to promote not just teamwork, but that climate conducive to effective team functioning. Seldom does a change in one area of an organization not affect other areas. And that's why understanding the teams present in the organization, as well as who's on those teams, is critical. Consider who needs to be included in the coordination, whether it's transferring a patient, piece of equipment, or critical information. Really think about who needs to be involved, who do you need to contact. That information needs to be shared not only within teams, but across teams, and the members really need to feel valued and able to speak up and share. Thinking about the video in Module 2, what if that lab technician had not spoken up about the change in the patient's status from his perspective? What if he felt the nurse will be in soon? He or she will notice, I have stat labs, I have my own work to do, and I have to get moving. Okay? And don't forget that most important part of patient care and the team, the patient. Research and experience are making it very clear that no healthcare organization can operate in a reliably safe way without the involvement of patients and families. You know, they offer that extra set of eyes and ears to the events unfolding around them. Embrace them, value them as an important part of the team. For who knows the patient better than the patient themselves? Patients and often their family have all the information. It's important not only to encourage them to actively participate in their care, but also give them permission to speak up and ask questions. Partnering includes educating the patient and their families on their roles and our expectations of them as being members of the team. When you consider a plan of care, it's critical to ask the patient if they're able to follow the plan. Don't just ask them if they understand, you know, and then you get that bobblehead response of them just shaking yes. But instead, use the check-back tool discussed in Module 3. Have the patient repeat back the plan and explain how they'll follow the plan. If you find they're not following the prescribed plan of care, ask why, and then listen to their answers. Listening to our patients and asking for their feedback is an important step in making them feel that they truly are valued members of the healthcare team. So before we look at a few examples of the worksheets that you've completed at the end of the module, are there any questions for what we've covered so far or what you'd like to be addressed? Okay, I do see one that someone wants to know, what about the patient who does not want to be involved or is non-compliant? Well, I think the important thing to do is ask why, first off. Communication is really key to that relationship building between our patients, families, and the clinicians. It requires listening and talking on both sides. As healthcare professionals, it is our responsibility to educate patients about their healthcare options and the expected outcomes of their choices. In your practice, I encourage you to consider the 3 levels of partnering with the patient when we're looking at team-based care from the patient's perspective. That care to me in the inpatient environment, care with me, that inpatient and ambulatory, and care by me. which is self-management. Attention to this third level, that self-management, is really key to reducing readmission rates. And I'm confident our guest speaker will have more to say about that in a few moments. Okay. Okay, so Module 2 worksheet asks these questions. Who are the members of the team experience a teamwork issue? Which team or teams within your multi-team system are experiencing the teamwork issue? And which team or teams interact with or are otherwise affected by the teams experiencing the issue? As you work with your change team, the answers to these questions should be discussed, and while it may seem a touchy topic, if it's happening in a unit or organization, it's most likely no secret who the people or teams are. And once identified and identifying who's affected will help in developing the next steps of your initiative. Who will we train? What tools will we be using? And what will be the desired results? So looking at an example that was submitted, this team has experienced a teamwork issue in the staff of radiology who are working in clinical subspecialties. And they've identified that those staff interact with the core team and the coordinating team. Ancillary team support services and administration are affected by this team. So in looking at these answers in this worksheet, I'd say this team has done a good job of focusing on the members and identifying those affected by the teamwork issue. Now, if you'd consider the patient as part of the team, you could also identify the patient as being affected by the teamwork issue. The last thing a patient needs to experience at a hospital or clinic is tensions between staff members, or have them wondering if they really are getting the best care when they can tell providers and staff are just barely disguising their frustrations with other staff or the environment they're working in. And then the second example is from a med-surg unit team who's identified that patient falls is the issue linked to teamwork that they want to address. As you can see, the members identified as experiencing the teamwork issue are the nurses and nursing assistants. The teams experiencing the issue then are that core team and the ancillary support services. And they've identified, again, ancillary team and support services and administration as the teams that would be affected by this issue. Okay. Which brings us to Module 3, communication. Not enough can be said about the importance of all staff having that shared mental model as they plan for the day, case, or procedure. Open communication and responding appropriately, including to unprofessional conduct or conflict, is critical to creating that safe environment for staff and patients. So how effective are the communication exchange strategies in your unit, in your organization? So before we move on, we have another polling question. So my organization uses a standardized communication tool such as SBAR, which stands for Situation, Background, Assessment, and Recommendation and/or Request. So if you'll just answer yes or no if you have a standardized communication tool that's in use. And then the second part of this question is, how often is that tool used? More than 80% of the time, between 50 and 80% of the time, or less than 50% of the time? Okay, so it looks like 70% of you on the call today actually do have a standardized tool, and that 50% of you say that it's use between 50 and 80% of the time, and 30% of you less than 50% of the time. Okay, so there's an opportunity for you as you complete communication and move through and think about what we're going to implement in your organization. Great, thank you for sharing that. So in Module 3, when we talked about the Joint Commission data on Sentinel events, identifying ineffective communication, 66% of the time was the root cause of reported errors. And to date, ineffective communication has remained among the top 3 root causes, along with leadership and not following policy or procedures. If you don't already know what your unit or organizational data reveals relating to the top root causes of the reported events, find out. In addition, identify your top causal factors for inadequate information sharing. The last thing anyone wants to hear, be it staff or patient, is, if I'd have had that bit of information this morning, an hour ago, yesterday, you fill in the blank. And we've all been there. Don't place your staff or patients in that same position as our dear penguins on the screen. The tools in the communication model, when used, will help your team overcome ineffective communication patterns. As with all the tools, this involves trust and respect. Trust that your team member has the patient's and your best interest as a priority, and respect not just for the patient, but for each other. Trust and respect that we are focusing on what is right for the patient and the team. And remember to consider and evaluate the effectiveness of your communication with patients. Have you employed the active involvement of patients and their families as a patient safety strategy in your organization? We've found that when patients and families know what to expect, they're able to monitor actions and orders relative to the expectation or plan and detect and, in a lot of cases, stop potential or unfolding errors. Like fully informed staff, fully informed patients and their families can help as we work to avoid adverse events and hazardous conditions. So we've got another polling question coming up and a few more worksheets. But again, I want to take this time to stop and see if there are any questions or comments. You guys are awful quiet today. Okay, I've got one question here. It says, before taking the course, I always thought SBAR was to be used in critical emergent situations, but the module discusses using it to convey information in other formats, such as shift change or with the patient, all of which now makes perfect sense. Has the application of SBAR evolved over time from emergent to more non-emergent, or has it always been appropriate in both circumstances? So SBAR provides that standardized framework for the team to communicate about a patient's condition. And while it's useful for framing any conversation, it's especially useful in communicating critical information that requires immediate attention and action. It creates a consistent format for information to be sent and creates that expectation for information to be received. When we use SBAR, it also enables the sender to have the conversation minus the emotion. And this can be especially important in specific instances. When in a particularly emotionally charged situation, and as appropriate, I've often asked staff to write down what they wish to convey in this SBAR format. This allowed them time to think through the situation, compose a meaningful discussion with that focus on collaboration and what is right rather than who is right. Standardized communication is essential for developing that teamwork and fostering a culture of patient safety. And SBAR as that standard communication tool is appropriate in many instances. It's critical that all staff are trained not only on the tools to be used, but also how the tools are going to be used in the organization. And then allowing staff to practice using the tools and behaviors in their daily work. And of course, holding them accountable to the desired behaviors. Don't see any other questions, so we'll move on. So in Module 3, you were asked to complete the worksheet by answering these questions. Is your teamwork issue related to communication? And if yes, what was that communication issue? And then you were asked to list which TeamSTEPPS tools and strategies you might consider implementing to address the issue. So as an example, let's say your communication issue was handoff, or perhaps lack of effective handoffs. So which TeamSTEPPS tools or strategies would you implement to address the issue? So let's use a polling question to see what you think. So again, which TeamSTEPPS tools and strategies might you consider implementing to address a handoff issue? And your choices are call out, SBAR, I pass the baton, and check back. Okay, so it looks like 40% of you chose SBAR as well as I pass the baton, and 20% utilized check back. And nobody picked call out. So, and call out is a strategy used to communicate important or critical information that informs all team members at the same time, such as a code or during an incoming trauma. So the leader may use a call out to inquire about the airway status, and then a team member would respond loud enough for all team members to hear, airway clear, and the same with breath sounds, etc. Because when all team members are informed, they're better able to anticipate those next steps. So SBAR, did you know, originated in the U.S. Navy submarine community to quickly provide critical information. It provided that standardized framework for sharing information. And then I pass the baton is one strategy designed to enhance information exchange, especially during those transitions in care. And check back is the process of using closed-loop communication to make sure the information sent is understood as intended by the receiver. So let's look at some examples of that worksheet you completed at the end of Module 3. So here we see Module 3 worksheet that's a follow-on from the radiology example previously discussed. And so they felt that they did have a communication issue, and it was that there was no formal structure of communication or workflow variations between modalities when patients had more than one modality scheduled. And they were going to consider implementing handoffs and call-outs to address the issue. So what are your thoughts about the tools they chose to use? Go ahead and type your answers in the Q&A box. So in this instance, the solution was to automate the digital distribution of certain changes for remote call-outs, and the automated call-out was readily available to all staff. So another consideration is to include the potential workflow variations during the morning brief, reviewing the schedule, sharing which patients had more than one modality scheduled, and what was the plan for the day to accommodate these patients. Sharing the known workload and the known available resources always makes that day go smoother. Okay, and so then our other example is from the team working on fall prevention. So the communication issue they wish to address is a shift-to-shift handoff and general unit awareness of patient risk. And they've chosen to use handoffs and SBAR. again, as tools or strategies to address the issue. And so as you progress through the modules, you may identify additional tools that you can add to your toolbox that will help mitigate or resolve your teamwork issues. So keep those in mind, and you can change your worksheets as you go along. So we touched on patient engagement in Module 2, and now it's my pleasure to introduce from Duke University Health Systems, Tiffany Christensen, who is a patient advocate and the director of Duke's Patient Advocacy Council. Tiffany, the floor is yours.
Hi, everybody. Really happy to be here. Thanks for having me. A lot of what I'm going to talk about for the next little bit here really piggybacks on everything that we've already heard. As we all know, having our patients and our families become a part of our healthcare teams is a popular ideal, and at the same time, it's something that we still grapple with. What does that actually mean? What does that really look like? So as a person who began this journey as a patient, I'm a double lung transplant recipient who began as a patient family advisor at Duke. I can say that one of the most exciting things that I've been involved in throughout my course of being a patient family advisor and now a professional advocate here at Duke is taking TeamSTEPPS tools and really incorporating them into patient-family engagement. The beautiful thing about TeamSTEPPS is that there are tools right there ready for us to use as partnership strategies to both decrease medical error and to increase patient-family satisfaction. So next slide, please. So there are words on how to incorporate patients and families into the team, and permission is one that I have learned the hard way is not one that patients and families respond to. The way that patients and families envision permission is that we are asking them permission to work on them, to touch them, to deliver care to them. And so by saying that we're giving them permission, I've found that that is not quite the wording that fits with that culture. And so what I've changed that to is inviting. We have to invite our patients and families to participate in their care, and we have to do that for a couple of reasons. One, simply because we have a relatively new culture in which patients and families are incorporated into the healthcare team, and that's something that not everybody is aware of or accustomed to. So we want to invite them simply as a way of saying, this is how we do things now, things have changed. We also want to invite them to the point of a question that came up earlier. We want to invite our patients and families to participate in their care because not everybody is going to want to participate in the same level and in the same way. So by opening the conversation, asking how would you like to participate, we'd love for you to participate, it gives us the opportunity to really assess amongst ourselves what that participation might look like for a particular individual or a particular family. And then while it is absolutely wonderful that we are inviting people to participate, I think we have to now go to that next step, that next level. It's not just about inviting and saying that we'd like you to speak up. It's also about providing the tools for which to do that, because that's a very ambiguous thing to say. We want you to participate can mean a lot of different things to a lot of different people. So once again, the beauty of TeamSTEPPS is that we have the tools right here ready for us to use to partner. Next slide, please. So, as you all are probably aware, patient and family-centered care is embodied by 4 guiding principles. Those are respect and dignity, information sharing, participation, and collaboration. And speaking particularly to the final guiding principle of patient family-centered care, collaboration, we have at Duke, if you wouldn't mind the next slide, please, really utilized our Patient Advisory Council, which was established in 2005 by the Chancellor, Dr. Victor Zhao. And this program has grown greatly. We now have not only a health system council, but we also have local councils on different clinical specialty areas like oncology and the emergency department. So one of the things that we have been able to do is we have been able to use the expertise of our patient family advisors to look at the TeamSTEPPS curriculum, which is taught here at Duke, and really ask them what tools can we be using to engage our patients and families. And so out of that, we have trained now roughly 12 of our patient family advisors as master TeamSTEPPS trainers, and they do teach modules at the 2.5-day training, or 2.5-day training, or 1.5, I can't remember. The master trainer training, they teach modules. And we've also created one of our modules, which is partnering with patients using TeamSTEPPS. And that's a lot of what you're going to be seeing here in the next few slides. If you wouldn't mind going to the next one, please. Oh, well, this part you already know. This is a lot about TeamSTEPPS, and we know that it's an evidence-based teamwork system and that it's based on the aviation model of safety so that we can be communicating better, provider to provider, in order to make a safer environment. You'll notice there at the bottom 3 bullets, I have highlighted some particular statements or particular parts of the sentences. One is to clarify team roles. Once again, we're looking at how does the patient and family fit into our team. And then the last 2 bullets there, we have resolves conflicts and improves information sharing, as well as eliminates barriers to quality and safety. If you may remember, one of the guiding principles of patient and family centered care is to provide information or information sharing. So what we're looking at here and what I'm really driving at is the fact that while TeamSTEPPS is certainly primarily a safety strategy, it's also an opportunity for us to de-silo, I think I just made up a word, to take away silos where they normally exist. Patient and family-centered care is often seen as one silo, and patient safety is seen as another silo. This really gives us the opportunity to incorporate the two in a way that they should be. Next slide, please. So these are the 3 tools we're going to talk about today. I will just say that we had a conference here at Duke in which we brought in several organizations from around the country who use TeamSTEPPS, and we had an all-day workshop where we were trying to figure out which tools would be best to use as partnership tools with patients and families. The end result of that workshop was that there was literally not one of those tools in our huge TeamSTEPPS book that could not be used as a partnership strategy. That said, we have chosen the 3 most low-hanging fruit, if you will. So those are the ones we're going to talk about now. Next slide, please. So we all know what SBAR is. It's already been discussed in this webinar. So we know that when it's used provider to provider, S is for situation, B is for background, A is for assessment, and R is for recommendation. You will see here that when we use this for a partnership tool with patients and families, we've slightly tweaked the SBAR acronym. So in my mind, and this can certainly be used in a lot of different ways in a lot of different areas, but in my mind, the most obvious ways in which partnering at intake would be used for SBAR would be in a clinical setting, in a clinic setting, or in an ER setting. So imagining that a patient comes into the emergency room, we give them this sheet that allows them to fill out their own SBAR. So why would we want them to write down their symptoms? Obviously, they know their symptoms. That's why they've come to the ER. But as a patient, I can tell you it's very easy when somebody walks in a room or when lots of people walk in a room and start asking me all kinds of questions about what brings me there. It's very easy to get white coat syndrome, where all of a sudden I can't remember everything that brought me here and all the symptoms that brought me here. And so by writing them down, I can ensure that I have been able to be complete in my description of what's going on with me, which of course is an important part of making an accurate diagnosis. Also, with background, you might say, well, a patient knows their background, and that's true, especially if somebody has a very limited experience with healthcare. That's a pretty easy question. But when you're talking to someone like me who's had 40 years of healthcare experience as a patient, that's actually a pretty tough question. Tell me about your history. So giving me the opportunity to take a few minutes and really think about what relevant background do you need? What kinds of things are going to be helpful for you as the provider to hear about my medical history, and then allowing me to have that time to write 1 to maybe 3 sentences of my background is going to allow us to have a much smoother and more concise conversation about my history. And then assessment, of course, it's the job of the provider to make the assessment, but in this case what we're really asking is, have you ever felt this way before? If you have, what did it turn out to be, and how was it treated effectively? Or perhaps this is the first time you've ever felt this way, and that would be a good jumping off place. Another assessment that one of our ER physicians has recommended that he does with his patients is when they come in, he asks them, what do you think is wrong? Because if I, as a patient, am sitting there thinking that I have a headache and it's probably a brain tumor, and my provider is sitting there thinking she has a headache, it's probably a migraine, that's really a good place to start a conversation. And then finally, request. Again, this is similar to symptom in the sense that I don't want to forget something like, oh, I need a prescription refill, or I'm cold, I need a blanket, or I'm a diabetic and I haven't eaten today, I need a graham cracker. Those are the kinds of things that can really slow us down if we have to then go back and circle back to answer those questions or to bring those things to that patient. So this allows our patient to get their needs met more quickly, and it also ensures that we have less trips back into the room. So the whole goal of partnering at intake is to allow our patients and families to have the opportunity to be concise and to be precise. Because what we all know is that in healthcare, time is gold. And so this allows us to get our thorough intake with the least amount of time spent on things that we could really streamline. Next slide, please. So this is my favorite tool. I love this tool because it's cuss, and if a patient or family is feeling frustrated, they may just realize that they feel like cussing, which may allow them to remember to use this tool. And you might notice that I have changed the acronym again just slightly. When it's used provider to provider, it's concerned, uncomfortable, and safety issue. I don't encourage patients and families to use the S for safety simply because that is a very loaded word. And if someone were to use that incorrectly when it was not in fact a safety issue, I would be worried that my patient would lose credibility. So what I have changed it to is scared. So if anybody here has ever been to couples therapy, and obviously I can't see you, so you don't have to raise your hand or anything, but if you've ever been to couples therapy, you know that we use I language when we speak in couples therapy. We say, when you say blank, I feel blank. And the whole point of doing that, it is an effective tool. There's a reason why our therapists ask us to do that. It's because when you're using I language, it really takes the defensiveness out of the conversation. So that person is more able to hear you when you begin the sentence with I. And this is a very similar concept. So if my provider were to walk in the room and I were to say to that provider, I'm really concerned about blank, I'm uncomfortable because of blank, and I am scared. There's really nothing in what I have just stated that points a finger at anybody and says that they're doing something wrong. And yet at the same time, I am able to communicate my concerns in a very effective way. I'm walking a fine line now between being an effective patient advocate and an offensive patient advocate, and this allows me to be more effective than offensive. So I love this tool for that reason. Next slide, please. And finally, the final tool we're going to talk about is partnering for safety, and this is a patient-family call-out. We know that we have providers that have safety call-outs. We also know that we have something called Stop the Line, which is in the same ballpark. So if we have a situation in the operating room where we feel like something is about to happen that is not appropriate or not the plan, we have the opportunity to do a safety call-out, and at that time, everybody is meant to stop the line line, listen to that person with that concern, and make sure that we address it before moving forward. This is a very similar concept in the sense that it is a tool that is given to patients and families in order to have that right and that opportunity to call out and stop the line if something is of concern to them. I actually know that in Tacoma, Washington, this tool is being used in Madigan Hospital. When patients and families are admitted, they teach them to use the timeout symbol with their hands if they have a safety concern or a burning question. And I really love that model of a patient-family call-out because, number one, doing the timeout symbol with your hands is something that we all are very familiar with. It's not medical mumbo-jumbo. It's not another acronym. It's something that I've been doing ever since I was a little kid. It's something I'm very comfortable with. So I really like it for that reason. I also like it for the reason that I can use that symbol even if I'm not physically able to use my voice. So that's another advantage to this symbol. And finally, the third thing I like about the Tacoma, Washington model is that they taught it to their patients. And I'm going to take a leap and assume that if you taught it to me, you're okay with me using it. And so once again, we're walking that fine line between being effective and offensive. And if you have taught me that this is the tool that you want me to use when I have a concern or a safety issue, then I feel more confident that I am being effective and not offensive. Next slide, please.
Thank you, Tiffany. I'm going to stop here and ask if there are any questions. I don't see any at the moment, but I do want to let everyone know that the questions asked today and their answers will be included in the facts section on the LMS. Those of you that have not scheduled your Teach-Back session yet, I encourage you to do so that you're able to schedule the time you want. The link to schedule your Teach-Back is located in the Module 5 activity. You don't have to complete any of the modules to access that sign-up roster. However, you will have to complete all modules and view the 3 recorded webinars before you perform your Teach-Back. We look forward to hearing of your progress and plans for implementation. So send us an email at questions@tslms.org and let us know how you're doing. We've just received another question, and they want to know how to enlist physician champions. That can be tough in some organizations. One technique I've used is to include your chief medical officer or other department chiefs in the training. Once you get a group of leaders from your medical staff going through the training, it's very easy for them to buy into the program. Sometimes it's just a matter of education. Often they don't fully understand what you're asking them to do or what that TeamSTEPPS is all about. Sometimes it's just not initially understood, but usually once folks sit through the training, they understand how important and how effective the initiative could be in improving the patient's safety within their organization. And don't forget to also engage staff. So when you identify an opportunity for improvement, involve the leaders of those areas. Of course, leadership requiring physician participation is always a plus to get them in the seats. But once they get in the seats and understand what you're trying to do and that it really can be fun, so please do make it fun when you present the training to your staff and colleagues, then you have buy-in. Sort of the theory that if you build it, they will come. And this usually works. But also sharing those outcomes that you've identified and experienced engages individuals into the process. Don't keep it a secret when you have a win-win. It's important to let physicians, or anyone really for that matter, know what's in it for them and their patients. Consider framing it as, we're looking to take great care of your patients. And then it's hard for even the most stubborn resistors to argue when someone says they're really doing something in the best interests of their patients as well as to make their day go smoother. Tiffany, thank you again for sharing your story with us. You've certainly given us something to think about as we work to enlist patients as active and engaged members of the team. I know Dr. Napolitano and his team at Madigan Army Hospital, along with teaching their patients effective communication tools, have developed a wonderful brochure called Team Up. This brochure is reviewed with patients and it actually explains TeamSTEPPS tools and the communication patterns to their patients. The brochure can be ordered from the ARC website, which I've done and shared with many of the organizations I've worked with and coached. So as this concludes today's webinar, I'd like to thank you, those in attendance, and wish you a great rest of the week. And you may now disconnect.